All right, buccal fat pad sculpting. So people talk about it as an easy procedure, you know, like throwing knives in the air or something. It's not simple, it's complicated. It's a complicated anatomical location, and it has complicated aesthetic implications. That's like, I could like wrap that, I think, or something. But okay, so I drew this before we started. These are the superficial fat pads in the face. So it goes skin, dermis, superficial fat pads. This is not the buccal fat pad. This is where we put fillers, this is where we do fat transfer, this is what makes the skin look nice and plump. The layer deeper to this is the facial musculature. So I drew that here. Just deep to the facial musculature is the parotid gland. I drew that. There's the parotid duct. There's the facial artery. All of these things are superficial to the buccal fat pad. So the buccal fat pad is deep to these structures. That's why we go through the mouth to get to the buccal fat pad. I've done this before in videos, and patients liked it. So it's an avocado, right? Here's an avocado. There's the bone. Yeah, get the bone out. So we have taking the bone out is like doing buccal fat pad removal. Buccal fat pad sculpting, allowing us to contour smoothly the outer surface of the face. That creates a shadow there. That really is the key. The meat of the avocado is the superficial fat pads. Those are the ones I'm showing here. So if you mess with those, that can premature age people. That can cause crinkling of the skin. That can cause compartmentalization of the face, which doesn't look good. That's what people don't like. People who talk about the buccal fat pad prematurely aging people, I don't think they understand this anatomy, because it's this superficial fat pad, or superficial fat, subcutaneous fat, subdermal fat that looks good. That's where we put fat when we do facial fat transfer. So that's a key point I really wanted to hammer home. All right, so why do we do buccal fat pad sculpting? There's a couple reasons. What is the goal? What people like, and I say that in quotations, but I know what people like. I make people happy. So look, they like a little bit of a shadow. Women do this, men do it also, surprisingly, with contouring their makeup of their face. So they like a little shadow there, and then they like a little shadow under the jawline. That's the snatched look, this kind of tight, they like these angles. So how do you get that? There's a couple ways to make that happen. You can augment the cheek, you can augment the jawline, meaning give those volume, project them out, and that creates a shadow under them. You can also sculpt or manipulate the buccal fat pad. Now I'm drawing this in its deeper plane. I've removed the superficial fat pad, I've removed the facial musculature, I've removed the parotid gland, the parotid duct, the facial artery, the facial vein, and the buccal fat pad. And the buccal fat pad goes right in here. It actually is contiguous up into the temporal fat pad. It has 3 lobes, an anterior lobe, an intermediate lobe, and a posterior lobe. There's a couple different branches of it. There's the buccal branch, or these are like finger projections. There's a pterygoid branch, there's a pterygopalatine branch, and there's a temporal branch. These are little fingers. We typically are messing with the buccal and pterygoid branches when we're manipulating this fat pad or sculpting this fat pad intraorally, but we can see them all if we work hard enough. At Cook County, I do a lot of trauma cases, so people who got a gunshot wound in his mid-face, if the zygoma's exploded, when we're reconstructing that zygoma, we see the buccal fat pad, all 4 interdigitations, and we're able to really appreciate that. So that's a nice thing I think I bring to the table. And that brings me to point number 3, why I'm the best. I think, as I alluded to earlier there, I have a unique appreciation of the facial anatomy. A lot of surgeons have this, but I have a trauma practice and I have an aesthetic practice, and they both kind of help each other. I've done a ton of buccal fat pad removal, sculpting, repositioning, transpositioning. I've now kind of finessed it to the point where I think I can make people happy. And there's another thing I do intraorally. People often bite on their intraoral mucosa. It creates a line of perikeratosis, it's called, and I remove an ellipse of mucosa there. All right, I'm gonna draw this part on the board. So intraorally, there's the mouth. Commissure there. This would be the parotid duct, Stenson's duct that drains the parotid gland. This is an intraoral view. People who bite their cheeks get these line of perikeratosis. So I remove an ellipse of that mucosa. Can vary from 1 to 2 centimeters. And if you bite on your cheeks and look in the mirror, it's that kind of a degree, that kind of a sensation. Now, in addition to that, the buccinator muscle, which has 4 bellies, this is deep to the mucosa, also deep to the facial musculature. It's actually deep to the buccal fat pad from the external, superficial from the internal. I take a few strips of that muscle, similarly to how we take a strip of the orbicularis muscle during blepharoplasty, just to tighten and further sculpt that area. All right, adjunct procedure to buccal fat pad removal, sculpting to enhance or sharpen, sculpt, snatch, all those things to the face. Kind of a classic one, I think everybody knows. You have the masseter muscle. It's actually the strongest muscle in the body per muscular unit, per volume. Think about an alligator, how strong you can bite down versus how strong you can flex your arm. Your masseter muscle is stronger. So you put a neurotoxin of some sort into that masseter muscle. I also think people don't understand why we do that. So the masseter muscle is a strong muscle, as I mentioned, so it's bulky. So it creates roundness. It's full of blood, it's beefy, it's red. If you operate on it, when somebody breaks their mandible, if you operate on it, it gets really swollen. It's round. It does not snatch you. So when you put a neurotoxin in the masseter muscle, it allows it to kind of become flaccid, and if you do it enough times over a long enough period, it becomes atrophied, so it's soft. Then what do you see? Then you see the angle of the jaw. The jawbone is made of calcium hydroxyapatite, made of a firm structure. When you get rid of the masseter muscle, you see a sharp angle of the jaw, and that's hot. Hot is hot. That's what people like. So that's why they do that. The downfall is you have to do it, recurrent and frequently, but we're happy to see it. So that's that. The other option, as I alluded to earlier, would be to augment the cheek. If you augment the cheek, you create a shadow below it. If you augment the jawline, you create a shadow below it. So that's with fillers. There are implants for this. Typically, again, I'm only doing those for reconstructive cases. People have these weird congenital anomalies or fractures, but it is an option. We have newer devices that have bipolar radio frequency. It sits on your face like this and slowly delivers bipolar radio frequency to narrow the buccal fat pad. Also, focal skin tightening. So people talk about skin tightening in the face. If you tighten the whole face, that's good. It'll improve the skin. It'll look nice. But if you can focally tighten here, you can get the illusion or the kind of some of the effect of what a buccal fat can bring. And another thing I beg patients to do, I've started giving them one included in buccal fat many times, where if you put a little bit of filler in the chin, it really can make a big difference, because as you lengthen the chin, you're focally tightening that skin in the superficial jawline area, which looks good. All right, remember, buccal fat pad removal, sculpting, it's removing the bone of the avocado, not the meat. The meat is the good part. The meat is the superficial fat. So remember that.
I wear my glasses up, Oh, you did it!
Come on, man.